Ready? Okay. So we're talking about bone and joint infections. I just want to throw the caveat out there that this is a gigantic topic, and each individual subtopic is actually one lecture, which eventually you guys will go through all of them as the second years know. But this is more of like a bird's eye view, and I'm going to try to go through as much as I can. We'll start with some questions to wake all of us up. Those are the objectives, blah, blah. I'll try to cover most of these, but we might not get to all of them. But let's just start with the questions. And we can just go around the knights table. Yes.
A 48-year-old man presents with a 6-month history of intermittent curative drainage from the distal third of his left tibia. 2 years ago, he sustained an open tibial fracture in a motorcycle accident that required surgical fixation. He has been on multiple courses of antibiotics. On examination, there is a small sinus tract over the anteromedial tibia with mild surrounding erythema. Plain radiographs reveal a loosened area surrounded by dense sclerotic bone. Which of the following best explains the persistence of infection in this patient's condition?
It's not fancy, it's just shorthands, right? How many pick A? So we already know the answer. It's just, you what now? Yeah, so this is hardware-associated infection. Speaking of which, I don't know if you guys have seen it, but there's apparently a new field now called implant ID, like transplant ID. There's implant, or at least we're trying to turn it into a specialization that basically has to do with any biomaterial that's implanted, which obviously the list is ever growing, right? So there was a recent article that just came out talking about how this could probably be another ID track. Just saying. Okay.
17-year-old boy presents with a history of intermittent slowly progressive right leg pain. He denies any preceding trauma to the limb and has no systemic complaints. Sam, localized centers of vertebral right tibia without warning, or swelling. Labs normal, white blood count, mildly elevated CRP-SR, blood culture to sterile. X-ray well circumscribed, driving lucent lesion and metastasis at the proximal tibia with surrounding sclerosis. 2 MRI 2 centimeter intramedullary lesions of bone marrow each.
What happened to the MedPeds resident? And I was gonna. Oh, there she is. Welcome back, Jenny. This question would have been nice for you to do, but I think most of you probably already know the answer. Okay. A, B, C. Shall I go back? Okay. Right, and the name kind of gives it away, right? Because it's a sarcoma, so there's always muscle involvement. So, although they can have bone involvement. So, it's a male kiddo, right? Like pain, and has this lesion. All right. C, D, E. Okay, yeah. So it's Brody's abscess, right? So this is a kind of a classic, like subacute to chronic osteomyelitis that has a predominance in the pediatric population, can present with single or multiple lesions, usually in the long bones, usually the tibia. And basically, there's an abscess within the medullary portion of the bone that then gets surrounded by like an involucrum, and then the abscess starts draining eventually. What's the most common bug? Any guesses that causes Brody's abscess? Jamie? No, sorry. Yeah, so it's always mostly staph, right? Like staph is always, like, you'll never be wrong if you say staph when it has anything to do with osteoarticular infections. Okay. Next.
The following domestically diagnosed.
Oh no, you got to read the whole question, man.
Yeah, I like starting at the bottom. So
Oh, my bad. You're doing it like the way you do it on the boards. Okay.
66-year-old man with an acutely painful left knee and ankle with associated swelling and the inability to pick. He had not experienced any fevers or chills. He had not received any recent antibiotics. He was known to have hypertension and atrial fibrillation on warfarin. He described occasional alcohol use. He had recently discontinued his naproxen secondary to gastritis. Labs show mildly elevated white blood cells, 11.2, ESR 44, CRP 3. Synovial fluid aspirate, 20 cc milky/opaque fluid, red blood cells 750, white blood cells 23,000, 68% neutrophils, crystal, microscopy, gram stain, and cultures pending. What is the most likely diagnosis?
A, B, C, D. Oh, thank God nobody said D. Okay. Oh no, come on, Barb. Okay. So in this case, it's actually crystalline arthropathy. And obviously, I would not have given you the crystal microscopy because that's too easy, right? So we'll talk about later on, we'll talk about why that is the case. So let's just move on to the next question. Okay.
40-year-old woman was in thoracic back pain in 2 months. Pain interfered with her sleep, and she was given opiates for the pain. She also noted intermittent low-grade fevers, denied night sweats, and weight loss. She also had no history of smoking, illicit alcohol use, and illicit drug use. She emigrated from Myanmar 4 years prior. MRI of the thoracic spine was done with and without ideal contrast, showing gross changes of the intervertebral bodies, T7 and T8, with relative sparing of the disc space. What is the most likely positive organism?
A, B, C, yeah, D, and E. Okay, so this is the classic presentation for what? Yes, pot spine. So the clues obviously is that she is originally from an endemic area, the location of the lesion, which the most common location of tubercular vertebral osteomyelitis is actually the thoracic spine, as opposed to other bacterial osteomyelitis involve the lumbar and sacral spine. And then also the anterior portion of the vertebral body tends to be more commonly involved with TB as opposed to the other ones. And then the vertebral body itself first gets infected, followed by the disc later on. So those are all your clues. And then we will also briefly touch on probably something that you'll see here, which is a risk factor for acquiring Pott's spine, which maybe the second years have already seen. That's in the field of oncology. Like, I'm just trying to throw out clues. Anybody? Actually, we can just talk about it now. Yeah.
Oh, are you talking about like a BCG06?
Yes. So, I think we've already seen, or we've had a case maybe within the past year or so of Pott spine being caused by intravesical administration of BCG for the treatment of transitional cell bladder carcinoma. And personally, my N is 3 for this, 3 or 4 over the past like 12 to 14 years. So, okay. So next question.
Strained it, like fever, rash, tick bite, or trauma. Past medical history has high blood pressure, has cholesterol. On exam, he's got fever, he's medically stable, his knee is swollen, it's warm, and there's confusion. Got fluid, you get a white count 35,000, 70% of which are neutrophils. There's no crystals, and the grand stain is why this is most likely.
So this is a 2-part question. That's why I don't have the MCQ here. But anybody want to throw out likely? Okay. What if it is a septic joint? What organism should you be thinking about in somebody like this?
Really?
Okay. Yeah. So obviously, like, you'll have 2-part questions mostly in the boards, right? So before you go on to the actual question, you'll have to first figure out what you think the diagnosis is. But this actually kind of gives it away, which is why I didn't show you this first. So this is actually borreliosis. So you got it. So now, which of the following statements is usually true for Lyme arthritis? How many pick A? No. B? C? D? Ah, I tricked you. Okay. So actually,
100%?
almost 100% sensitivity. Because, and why do you think that would be with Borrelia arthritis? Why would it approach 100%? Any thoughts on why the two-tier testing would be that real? Okay, so two-tier, sorry. Okay, so two-tier testing basically is you do the ELISA for Lyme antibodies, and then you do a confirmatory Western blot or immunoblot to IgG and IgM to Borrelia. So the reason that happens is because arthritis is a late manifestation of borreliosis. So by then, they have all acquired the antibodies, which is why the first test is actually the serum testing, and actually it's more sensitive than the PCR on the synovial fluid, although you would think that it would be the other way around. You should do both tests, but if you have this positive serology, you don't actually need to do the PCR, you can just do it to confirm. So, and it does present as a single, usually a single joint arthritis, usually a weight-bearing joint like in this dude, so like the knee is the most commonly involved joint, and it can look very impressive like an actual septic joint when it's inflamed, and it can present up to 2 years following the original infection with the Borrelia. Even if they have been treated appropriately, they can still have a relapse, and usually it's not seen in the early disseminated Lyme stages. So the synovial cell count is usually lower, so that's why like I gave you a 35,000 count. So usually it's between 20,000 and I would say 20 and 75,000. So, but tends to be more so on the lower end. Yes. And sorry, yes, I just want to finish my thought. So for this entity, you do need ceftriaxone for a longer period of time because this is a late manifestation. So this is really the only indication where you would do the 28-day course of IV ceftriaxone. Okay, continue.
I was trying to think of a solid pattern to remember in my head where there is higher sensitivity for the antigen tests versus PCR. I know a lot of times in viral rigidities, CSF, and now in this, and I'm trying to think what could be something I could type together with in my head, or is there anything that's known in the research? Or?
So no, not really. It's obviously these are all different organisms, right? So for Borrelia specifically, you'll just have to kind of and really the best way to remember these things is to actually see a case, right? Once you see a case, it kind of cements it in your brain. We don't see it much here, but sometimes we might, like because we do have snowbirds, and they might be down here looking for houses or something, and then come in with a knee. But yeah, they just have to remember that. And then this is really the only situation where the serology is actually more reliable than the actual molecular PCR test. I can't really think of anything else where we're saying serology is better than PCR. Let me think.
Arboviruses.
Maybe arbo. Yeah, this one and arboviruses, it would be the only one. And then maybe also, yeah, there's very few things where, yeah, like convalescent serology. So there's very few things where it's actually the serology is more reliable than the molecular testing. But I think there's a false sense of security that we feel when we see the word like the PCR phrase, because it's like, well, at PCR, but that's not, it doesn't hold universally true. And also the other point is, if it's usually a multiplex PCR panel, it is not the same as getting the individual PCR for most of these things. Like, for example, with HSV meningitis, the PCR on the multiplex panel might not be as sensitive as the single probe PCR. So good question. Okay, next. Don't know who's next. Who's next? Jamie. Oh, Jamie should have read this one, but you can go on.
ESR.
This is an adult ID board question, by the way. Okay, how many pick? I know, I should have put that as E. Okay, how many pick A? preceding respiratory illness, now presenting with blah, blah, right? We're now presenting with a knee. That's, wait, is it a knee? Left leg. Yeah, knee. Sorry, who picks B? C? Okay. Yeah, he's, well, I didn't say that specifically, but sorry, this is has sensible parents and is vaccinated. And hip vaccination, by the way, starts at 2 months, just FYI. So like he's fully at this point vaccinated. Okay, and how many pick D? Yes. Okay. So this is actually Kingella kingae, right? Have you seen a case here yet? Okay. So this is like a classic presentation for this specific organism. Do not ask me why. I do not know the exact reason. But Kingella kingae, which by the way belongs to the HASEC group, causes this entity in children usually less than 4 to 5 years old, where they will have a preceding viral illness, and then they will come in with a septic joint, and it'll be Kingella kingae. It's a very fastidious bug. You cannot just grow it in routine cultures. You actually have to inoculate it into blood culture bottles and hold it for a long time, and you might need to do a PCR panel. So it's like a very weird entity that I just wanted to throw out, like a zebra for funsies. But yeah, sorry, this stem is very long, but so if you want to just read it in your head, that's fine.
Fine.
Or you can read it. Yeah.
69 years old man with a history of right total knee arthroplasty 4 years ago, presents with gradually worsening knee pain and swelling over the past 2 to 3 months. He underwent arthroscopic debridement 5 weeks ago at an outside hospital. Cultures at that time grew Candida albicans. He has been on oral fluconazole since then with partial improvement. On exam today, there is mild warmth and swelling of the joint without systemic signs. Repeat aspiration grows Candida albicans. Candida albicans again. He has no immunosuppressive conditions and normal renal function. Which of the following is the most appropriate next step in management?
It's DAI.
We'll talk about it. But it's debridement, antibiotics, and implant retention. Okay, so the second years, do you want to tackle this? Or the first years? Right. I mean, you've seen it. This is Candida prosthetic joint infection. The answer is always surgery, just like with Candida endocarditis. Kind of remember it that way. It's not going to be cured with antifungals. You can give him antifungals till the cows come home. So the answer is 2-stage exchange. So per the IDSA guidelines, which are pretty recent for this particular entity, it's always a combination of removal. And if you need to reimplant, you need to separate the reimplantation by at least 3 to 6 months, because otherwise they'll have a relapse. So unlike in bacterial PJI, where it's much shorter, right? So 2 stages separated by 3 to 6 months and a prolonged period of antifungal therapy. So it's at least 12 weeks after the resection and then 6 weeks after the reimplantation. So it's a very long course as opposed to bacterial PJI. So, and that's not really based on any RCTs. It's just based on, expert opinion, limited data, retrospective stuff. So, okay. David.
A 72-year-old woman underwent total hip arthroplasty 9 months ago. She now presents with progressive hip pain, limited range of motion, stiffness for 3 weeks. ESR is 55, CRP is 2.8. Synovial fluid aspiration yields turbid fluid with a white count of 2,400 and 78% neutrophils. Which of the following statements is true regarding her synovial fluid analysis?
Sorry, I should have said PJI. I said PJ. Did I also change her gender? I hope not. Okay. How many pick A? B. I see the half hand. Okay. C. D. All right. So since you answered, what do you think is the cutoff, just for funsies? For PJI.
For PJI?
It's totally different than for native joints, people, which was the point of this question.
I would say like
60% what? Like the absolute number cut off.
Oh,
Like for septic arthritis of native joints, it's like over 50,000, right? What about for prosthetic joint? What do you think the cutoff is?
1,000.
Close. Okay, so it depends on the joint actually, but for in general, it's over 3,000. But if it's a knee, if it's a hip, it's 1,700. So for hip joints, this would be actually true. And then more than 65% neutrophils, so it's already, so she does have a prosthetic. 1,700, weird number for hips. And for knees and other joints, it's 3,000. Because the knee, obviously, because it's a weight-bearing joint, you might have baseline increased, inflammation. But this is a prosthetic hip. This is a PJI. Okay, I guess it's my turn. A 62-year-old man presents with gradually worsening right shoulder pain and stiffness 18 months after a reverse TSA for rotator cuff arthropathy. Denies fevers, chills, or erythema at the surgical site. Labs show a ESR, blast, ERP, it's all normal. X-ray shows mild periprosthetic lucency. Synovial fluid analysis is 1,100 with 68% neutrophils, and cultures are pending. Which of the following is the most likely causative organism? How many pick A? Please don't pick A. Okay, good. How many pick B? B, maybe. How many pick C? It's always C. D? Me. So it is QT bacterium, previously known as propionibacterium, but I vastly prefer QT bacterium. It's just cute. No, it's because it's on the cutest. But so if they give you shoulder joint and like a very mild looking thing happening years after the implantation, the synovial fluid analysis, usually in this case for C acnes, will be around 1,000. So that's kind of classic for this, but it's always QT bacterium. So you need to tell the lab that you need to keep the cultures for at least 14 days. And the reason why is because QT bacterium loves armpits and this whole trunk area. So obviously the shoulder is right there. And so that's the most common organism. Coraini is usually not seen in the shoulders. And usually you need an open wound for Coraini striatum PJIs. Okay.
Which of the following is the most common risk factor for acquisition of sternoclavicular joint septic?
How many pick A? B? C? D? Yeah, okay. So again, always C, right? So these are all risk factors for sternoclavicular joint septic arthritis, but by far and away, it's IVDU. We had a patient recently. Who was it? Was it you and me who had it? Not you, but there was a guy that had a horrendous sternoclavicular joint septic arthritis. It was us, but I'm trying to think who the fellow was. What the heck? Was it you?
Sorry.
The guy that we were suspect because he had severe sternoclavicular.
Yeah.
That was just recent, right? And he
guy with Crohn's.
correct, but his UDS ended up. Nobody had checked the UDS on this dude, and obviously it was positive, but. Yeah, so the the exact mechanism is not known, but the thought is the valves and the veins are letting in these components from and if they especially, and also some people with IDU disorder will inject between the heads of the sternocleidomastoid muscle, and then that's kind of right there. So some will go into the neck and shoulder if they're getting desperate, running out of IBE sites. But
I remember this patient, he had this other weird history of all these
he did. He had skin picking lesions. So it was a very classic person with IDU disorder. But yeah, that's really these are the only situations where you'll see sternoclavicular joint septic arthritis. It's very otherwise not common. And usually, and if you see it if it's severe enough, it can also lead to mediastinitis. And so obviously you need to be aware of that. So we all know osteomyelitis is an inflammatory process involving the bone. And really any part of the anatomy can be involved, triggered by infection that then leads to avascular necrosis. So basically it's dead bone. And that's the sequestrum, right? So sequestrum is dead bone, and the surrounding area is called the involucrum, just if you're trying to be fancy. And then the classic thing in chronic osteo is always biofilm formation because the bacteria are kind of just hanging out in there in this really inert extracellular matrix situation. And that's why it's a chronic entity. So there's multiple classifications for osteomyelitis. Obviously, the classic is DFI, with contiguous osteomyelitis. but you can have hardware-associated osteo. There's multiple classification systems. These are the two that are most commonly used. So this first one classifies it by mode of acquisition. So is it hematogenous? Is it contiguous? Is it secondary to vascular insufficiency and a reduced blood supply? So that's where the DFI falls. So and also exogenously acquired from a skin source. So, and then you have the anatomic classification, which you don't really need to know about. It's really more so for the surgeons, but it defines it specifically by where in the bone you're seeing the osteo. So this is kind of a nice, I think, pictorial representation. So depending on whether you're a kid or a grown-up, it's very different, right? Like in kids, it's usually acute hematogenously acquired osteo. It's very dramatic, whereas in adults, the most common form you'll see is the chronic osteomyelitis. So this is the dead bone, and then the involucrum that I was just mentioning, and then that's how you have the sinus tract. We've all seen this. And then you have this Brody's abscess, which can involve the subperiosteal area, and it can also be deeper. And they have this weird term for a Brody's abscess having a cloaca like birds do, but just kidding. So in terms of which bugs, it's always staph, and more staph. In any osteoarticular infection, it's always Staph aureus, the most common across all skeletal infection sites. And then there are these weird little associations. For example, the Kingella kingae that I mentioned. Haemophilus used to be a huge thing, except vaccination fixed that. That's why the answer was not Hib in that question. And then we were talking about QT bacterium being in the upper extremity. For the spine, you need to think of things like MTB and brucella and some of the fungal thingies. For periprosthetic joint infections, again, it's always gram positives, right? Like for osteoarticular infections, but you can have gram negatives, pseudomonas, even like the enteric gram negatives. If it's trauma, things change, right? Like you can have more other bugs like anaerobes even, and usually polymicrobial infections. For head and neck osteo, actino, always think actino. For head and neck osteo, like jaw osteomyelitis with hardware. Hematogenous is the point, like people with sickle cell disease have a predisposition to salmonella osteomyelitis. We all know that association. Gonococcus, another OG septic arthritis bug. So this was a really nice review in Nature, actually Nature Reviews it's pretty recent, that had this really cool picture. So moving on, I'm going to try to go through most of these entities. We're done with the questions. I think there were 10 questions. So let's just talk briefly about native joint septic arthritis, also called apparently SANJ or something, septic arthritis in native joints. I'm not calling it that. It sounds weird. So never let the sun set on a unilateral pleural effusion, but also never let the sun set on a red hot joint, right? We all know that. Yes. So always tap if it looks red and hot and painful. You have to consult the ortho bros. You just have to. And if you think, yeah, yes.
I told them, I think this is out, but I don't
never do that. Never do that. Yeah.
It's like, well,
call room. They say call rheumatology because that's their thing. Yeah. Right. So
use that word, then they're like, oh,
you have to word it right. That's very true. And you have to call them personally. Like if you're thinking somebody has a septic joint, don't just be like, patient has a septic joint in your note. You have to tell the team. You have to tell ortho. You would hope that the primary team is already on it. And most of the time they are. But if the patient is stable, try to hold antibiotics is the other thing. I mean, obviously, if it's Staph aureus, if they're bacteremic, you're not going to do that. But, if they're hemodynamically stable, ideally you should be holding. However, giving a couple doses of antibiotics is not going to affect the yield as much. And this is obviously only native joints, right? Like we're not talking about PJI. So just wanted to throw this table in here from Chalk Talk. So if it's not inflamed, it's usually less than 2,000. If it's an inflammatory joint, usually tends to be in the low thousands to low tens of thousands. Septic joints, usually it's 50,000 and above, like more so like hundreds of thousands if it's a true pyogenic septic arthritis. And the percentage of neutrophils, like these are the cutoffs. And then obviously if it's a crystal arthropathy, you're going to see either the CPPD or uric acid crystals. Do not check a serum uric acid level. It's useless, right? We all know that. And then gram stain, with the more virulent bugs, you're going to see the bug on the gram stain. And what else did I want to say about this? So hemarthrosis is also a thing. So obviously you need to do the RBC to WBC calculation. And like I mentioned earlier, if it's a prosthetic joint, the cutoffs are much, much lower. So always know that. And if it's a low virulence organism, you can have lower counts and still have an actual septic joint. So usually the ones that are the most dramatic are Staph aureus joints. Like that's where you'll see 200,000 white cells and they're actually draining pus from the joint. But if they've been either partially treated with oral antibiotics or something, somebody's been putzing around and they've gotten some antibiotics and it's a strep joint, it might not be that impressive. You might just have 50,000 cells in there or something like C. acnes. But C. acnes, again, wouldn't present so dramatically. So just keep these things in mind. You can get an X-ray. You can consider imaging and all that nonsense, but really it's synovial, it's arthrocentesis. You have to get the fluid out. If ortho says, oh, the range of motion is intact, this is not a septic joint, but if you're still suspecting it because the patient's already been on antibiotics, you just need to push them for it. So never let the sun set on this. Yes. Yeah.
What's the role of next-gen sequencing?
Yeah, so I was going to mention that later on, but yeah, so that's like the new thing, right? Like molecular sequencing, next generation. There's been some studies that have shown utility for that, but really it's only going to be useful where you don't have, like where it's an atypical organism or you're not getting your answers obviously on. Yeah, and if they've been on antibiotics, and you can send like the actual synovial fluid and not just the serum like Carius. So there are panels, but I've never sent it on a joint here, and I don't know that we
Ortho does that a lot.
have the. Yeah, but again, we don't see the joints here, right? Like it's mostly the private group. So like, I don't know what the latest modalities are that they're using, but if you've seen it, then they must be using it. There's also all these newer markers for, not so much for this, but for prosthetic joint infections. There's, alpha defensin and calprotectin, all that nonsense. But some of them do hold some promise. But for a native joint, yeah, I think molecular sequencing is going to become the like test du jour over the next several years. But okay, so differential diagnosis. Anybody just throw out names? Acute monoarticular, most common bugs. Yeah, staph and strep. And then GNR is like less than 20% usually. And you typically need risk factors for that. Polyarticular, there's two entities, right? So can be Neisseria, yes, gonococcus, but what else? If it's polyarticular, inflamed joints. Right, so it can be viral. And what's the other entity that's polyarticular? Can't see, can't pee, can't climb a tree.
Reactive.
Right, reactive arthritis. So those are the two things. So you can follow GI illness usually. We've seen several cases of this, and then viral stuff like you said, chikungunya would be the first thing that comes to mind. But chikungunya is also different in that it can cause chronic osteoarticular manifestations. And then gonococcus, yeah, can present as mono or polyarticular, especially in DGI. You'll have polyarthritis, right? And it can be migrating. So the joints can actually change, the ones that are inflamed, and you'll have the classic skin lesions on the flexor surfaces, and tenosynovitis is another common manifestation. Okay, chronic joints, any thoughts for native joints? Chronic septic arthritis, bugs? Like low virulence stuff, yeah. What else?
TB.
Yeah, TB is never wrong with TB, right? So like mycobacterial, fungal, yes, you said Candida, dimorphic fungi, even sometimes mold in the right host, and then obviously we talked about Lyme as well. So, okay, so let's move on to native vertebral osteomyelitis. Shifting gears. I'm not going to go through this worksheet. I was actually going to go through the whole thing, but let's just go to, and we kind of briefly touched on this, but native vertebral osteo, the initial workup is always, if you're suspecting that somebody has vertebral osteomyelitis, the initial workup you should always start with blood cultures. Why is that? Right, so like, exactly. So, and which bug that does that universally apply to? Right, so it's Staph aureus, right? Like we'll see this all the time. That's one of the most common sites of metastatic foci for high inoculum endovascular Staph aureus infection. So if you see spine pain and Staph aureus in the blood, that's the Staph aureus that's in the spine. So you don't actually need a tissue biopsy. Whereas for anything outside of Staph aureus and probably brucella, you do need biopsy, because lower virulence organisms, you can have two different things. So you can have one thing in the blood and one in the spine. So for example, if you just have strep mitis in the blood, you're not going to assume that it's the same thing that's in the spine. You have to get a tissue diagnosis for microbiology. The other initial workup, obviously, you can do inflammatory markers and, take them with a grain of salt. And the gold standard imaging modality is an MRI. So if the MRI obviously shows osteo, you go down this pathway. If it doesn't, then you have to look at other reasons. And I just had a patient 2 days ago who she has metastatic cancer of the cervix, randomly started complaining of right shoulder pain and severe neck pain. They were about to discharge her. When I came in on Monday, I went in and just palpated her spine, exquisitely tender. She had not had this on Friday or Thursday. So MRI, she has discitis and osteo here, and so she's not going anywhere, and her blood cultures are negative. But exam, always start with a good exam. If they have new point tenderness on the spine and any risk factor for getting this, like if they're looking, obviously if they're febrile, getting toxic, then something's going on, right? Like for Staph aureus, I think we're pretty good about getting spine imaging, but outside of that, like if they are not bacteremic with Staph aureus, I think that we need to have a higher index of suspicion to actually make the diagnosis, which is why I brought up this patient. So if it's consistent with vertebral osteodiscitis and an abscess or something, then obviously get the neurosurgery bros involved, especially if there's compromise in the spinal cord, right? Like if you have alarm symptoms, cauda equina and all that, you have to get them right away. No, they're chilling, like, they're okay, but they have the severe pain, then you can putz around and like don't start antibiotics yet, and then do more diagnostics, right? If their blood cultures are positive, you're great. Like I said, for Staph aureus and Staphylococcus, which obviously is like Staph aureus also, you don't need biopsies. But if not, then you do need biopsy. What if their blood cultures are negative? Then obviously get an image-guided biopsy, get the tissue for cultures, get it for histopath. Although histopath can kind of be not that useful here because they just get like one chunk, right? So they can miss the area. So it can be false. But if their culture is positive, yes.
So the pinkish plot,
yes,
evaluate for image-guided biopsy.
Yeah.
I'm in a situation with the hospitalist.
Yeah.
Kind of like back and forth.
Mm-hmm.
Friday.
Mm-hmm.
High suspicion for osteomyelitis in the spine. Nothing could be done until like Monday or Tuesday until bone biopsy.
Right.
So the hospitalist, like, I'm starting antibiotics. Biopsy is the guideline. So
yeah,
where
this is an argument since time immemorial. This happens here all the freaking time. Basically, if they're hemodynamically stable, afebrile, non-toxic appearing, and no neurologic compromise, you have to hold. The recommendation is that you have to hold antibiotics because you mess up the yield, especially the longer you give these patients antibiotics, the more the yield will be lower. Like, so you need to kind of try to educate people and say, if they crump, then please feel free to start antibiotics. But if they're stable, then you really need tissue before you start throwing antibiotics at them. But a lot of times it's hard to convince people, but that's the actual right answer, right? So, right. But they're fine. And then like neurologically, yeah, they're fine. So yeah. The weekend thing is real, man. Okay. So what happens, if they get like the vancomycin bag in the ED, that's fine. But like beyond that, just stop it. So if their culture is positive, yay. Okay. If it's negative, what the heck do you do then? So maybe get another biopsy. Nobody's going to listen to you. You can try, but then nobody's going to do it. Or get the spine bros and say, can you get me an open biopsy? And they'll say, nah, bro. But you can try. Or most of the times in the real world, what we end up doing is treating empirically based on like their underlying risk factors. And it's unfortunate, but this is, a lot of the time this happens. It happened in the VASPA all the time when I worked in a VASPA, and I'm sure it happens here. And then and you can try Carious, but again, I don't know that it would be that use. Like, I don't know what the data is for Carious specifically for NVOM. Like, it can be negative, right? But if it's positive, great. Yeah, so I'm glad you mentioned that. And also, obviously, review their previous culture data. So this is why we need to be reviewing people's previous cultures. That's why ID obsesses about this. Like, go back 2 years at least. And if they keep coming up with the same bug, it's probably the same bug, right? So just think of that. Okay, PJI. Let me see how much of that. I don't think I have that much left. Okay, so there's clear data that people with BMIs over 35 have an increased risk for PJIs. Number one. Number two, you'll see it mostly in older individuals because obviously older individuals are the ones mostly getting joints, right? Other risk factors for PJI, if they're hyperglycemic around the time of surgery, probably will end up with a PJI, maybe. RA, so any inflammatory arthritis, underlying inflammatory. RA is a big one, actually. So, because a lot of people with RA will need prosthetic joints. And so they do have an increased risk. Anybody with obviously other immunocompromising conditions. And then lymphedema, weirdly, is another risk factor, blah, blah. And then also these drugs do increase your risk of PJI as well. So any DMARD, which they'll be on for RA, right, for example, or other inflammatory arthritis. And then if they've had any revision surgeries, so the more you mess around with the joint and the more joints you put in, the more like the risk for acquiring PJI. And if they've been bacteremic within the past year, that can also increase the risk for it. So surgical risk factors, like if they're in surgery for a long time, that has been shown to increase the risk. If they have like a big hematoma that had to be evacuated, any wound issues, all of these things increase the risk. The problem is that there's no good consensus definition. So there's multiple definitions that multiple societies have come up with, but there's no universal definition of a PJI actually. But there's scoring systems, algorithms, all of that. So, and obviously you can have a early onset after surgery, which usually they acquire during surgery. You can have delayed PJI within the first year or two, and then you can have a late PJI. So for late, usually it's the hematogenously acquired infection, but for early and delayed, it's usually acquired during the time of surgery. So so you can classify basically PJIs based on when they acquired it and maybe the mechanism of infection and the clinical presentation. So acute PJI is not subtle, right? Like acute PJI, early onset PJI tends to be obviously acute, and so it'll be a red hot swollen joint, and you kind of have your answer once you get the tap. So, but obviously the clinical presentation can be highly variable. If it's a more chronic or delayed infection, they will have very indolent symptoms. They can actually develop sinus tracts. They can have delayed wound healing. And then if they're bacteremic, obviously they will have the systemic toxicity associated with that. But the most common symptom of PJI is pain. It literally is just pain. You can just have a painful joint, and that could be infectious. So the other point I want to make is that it's the most common cause of hardware issues, so hardware loosening. So in the setting of chronic prosthetic joint infections, they will start having hardware issues in addition to the pain. But if they have a sinus tract, you already kind of have your answer, right? Okay, so this is where I was talking about like the newer markers, that alpha defensin. There's lots of papers on alpha defensin now. It's like very fashionable. And then also calprotectin, both of which are sent from the actual synovial fluid. And then when they go to the OR, you need to be getting multiple cultures. The joint can actually be sonicated, which I think we talked about that last year, but you basically shake the freaking prosthesis into fluid, and then you hope that the biofilm is dislodged and the bacteria will get into the, yeah, so it's pretty cool actually. So, and this is what I was mentioning, the 1700 cells cutoff. Please remember that for the exam and just for real life. And molecular testing is also, again, there's a BioFire, right? So it'll probably be BioFire only in a few years, but you should get radiographs because you can see hardware issues. Imaging, you can do any of these things, but again, this is, get the fluid first and then look at all the imaging stuff. At least get 5 to 6 samples in the OR, and ortho is actually really good about this. Most of the time they get like multiple samples. You need at least 5 to 6. You can't just do one culture. And a few doses of antibiotics should not affect the yield, but if they've been on antibiotics, you might end up with negative cultures, which is where the molecular sequencing comes in to help. So like I said, there's no universal definition, but if they have purulence and sinus tract and multiple cultures, you kind of have your answer. But if you just have like one culture from the joint with staph epi, that's where you need to use your clinical judgment and see, like, is this even real? Is this just a skin contaminant? Is it QT in the, or, if you grow, for example, QT bacterium from a shoulder, then it's probably real, right? Like if you meet other criteria. So Not going to go through this one, but this is just one of the more commonly used criteria for diagnosing an actual PJI. You need to meet major and minor criteria. And then this one, this is where I'm going to explain the DARE and stuff. So the surgical and medical management of prosthetic joint infection, if the duration is less than 3 weeks or less than 30 days, and there's no hardware loosening, no sinus tracts, and known pathogen. What's the most common, or what's the recommended surgical modality for these joints for PJIs second years? So, we all know about DARE and single stage and double stage, two stage, right? So out of those, which patients qualify for DARE? So debridement, antibiotics, and implant retention are these patients, is what I'm trying to say.
Still like a 60%. It's only a 60%
So,
success rate.
So it depends on the temporality of the infection, and it depends on the bug, but there's actually some promising data for DARE, but they need to meet these very strict criteria. Which are these criteria? So if it's a more acute presentation, so less than a month since they just had the joint put in, and they don't have any of these things, then DARE does have a much higher success rate than otherwise. So that's debridement, antibiotics, and implant retention, PO or IV. We know about the OVIVA trial, but the OVIVA trial does have a lot of caveats. And, if you're using penicillins, it's not as reliable. But if you use like Bactrim, for example, for Staph aureus, but susceptible, then, you can get away with just honestly oral antibiotics after the initial IV. The duration of therapy for DARE is the longest, obviously, because the original joint is still in there. So for Staph aureus, especially, you need to be treating them much longer. So 24 weeks and at a minimum 12 weeks. And if you're retaining the joint, you need to add rifampin for Staph aureus. It's clearly been shown to benefit, especially in knee joints. So you have to test for rifampin susceptibility and add it on to the other active drug. You should never do rifampin monotherapy because you will lose it in a matter of days. Candida, never do DARE. It's going to fail. But everything else, there's a couple of trials that have said like 12 weeks might be enough. That was the DATIPO trial. And then chronic suppression is falling out of fashion. Like you really need to be having a discussion with the patient and the surgeons because really the data for it is not the greatest. But if the patient absolutely cannot get another joint and they have other comorbidities and it's really limiting their quality of life, if they have limited life expectancy, then you may consider chronic suppression, especially for the higher virulence bugs like Staph aureus, right? Like at that point, you're just palliating. Never lifelong, right? Nobody's going to be agreeing to being on antibiotics lifelong unless they may be 80 years old. But usually it's a minimum of a year and then reassess, or 6 months to a year and then reassess if you're doing it. Yes. It is, but you should still test susceptibility because if it's not, then yeah, and obviously rifampin, the main limiting factor is DDIs, right? Like, so a lot of these patients, unfortunately, will be on other agents that will preclude the use of rifampin, usually anticoagulants, right? We've run into this multiple times. So most of the patients, unfortunately, end up not getting rifampin, but this is the situation where you should be using rifampin. Yeah.
In those cases
You could, yeah, if you're able to mitigate the drug, but the data is not as strong for rifabutin, obviously. But there have been cases where we've used rifabutin. So I think it should be obviously done on a case by case basis. And then the other modality, if you're not taking the joint out, that's DARE, right? So then you're taking the joint out, but you can take it out in multiple ways. One is single stage exchange, where you go in, not you, but orthobro goes in, cleans everything up, takes the whole joint out, and then puts a new joint in right away. Europe has been doing this for decades. They have great success rates with single stage exchange. The US, we tend to do more, if we're doing two-stage exchange, if we're doing joint removal, we tend to do more two-stage exchange, although the pendulum is now shifting more towards single stage exchange. Also, just another point about DARE, you are still taking them to the OR to debride things. And this is where you will exchange either the liner or just the modular components that's there. So you're keeping the original joint, except you might sometimes remove certain parts of it, like the surgeon will decide that. So, but usually it's the liner. So coming back to prosthesis removal, if you're doing a 2-stage exchange, that's really the most definitive way of curing these infected joints. So you do the surgery, take the joint out. They will usually put an antibiotic impregnated spacer in there, and then you do antibiotics. And you have to give them a minimum of 2 to 4 weeks holiday before you put in a new joint. Most of these patients will not get a new joint for at least 4 to 6 weeks. And then some groups will actually do an antibiotic holiday. So usually you're meant to be doing an antibiotic holiday to make sure that their inflammatory markers are okay off antibiotics and everything looks clean before you put in the new joint, which is why the surgeons will say we need an antibiotic holiday for this procedure. But we won't see it as much anymore. I don't know how much our ortho people do it here, but usually we see single stage exchange, but that's when you go in and take the old joint out and put a new one in. And then obviously salvage is arthrodesis, where you fuse the joint. So you essentially put like a rod in there so they won't have any mobility. Really, I mean, they will, but it'll be very limited, or you just amputate the limb. And some patients actually prefer amputation because that gives them increased mobility, funnily enough.
Just keep coming back.
Yeah, so usually you're doing salvage if that's the case, like where you've done it there and it's come back. And it's really, again, affecting their quality of life. Like they don't have any mobility. They still have a painful joint and they really don't want to go through yet another procedure. These are salvage. So most patients will not get this, but there are a small percentage that will. Most of the time, if this fails, they will go to a single stage exchange if they can even put the patient on the table. But unfortunately, there are some elderly patients and people with comorbidities that can only really go on the table once. So that's kind of the challenge. But you will see all of these things once you rotate through TGH and the VA. So yes,
See a lot more of this at the VA.
yeah, the VA is where you'll probably see most of this. And this is just another, I'm not going to go through this one, but it's another pictorial representation of the same thing that I just talked about. So and then I didn't go into the details of the recommended antibiotic regimens because, again, that's too much for like this lecture that's covering multiple topics. So lastly, DFIOM, right? So this is our bread and butter. You will see this everywhere, probably mostly at the VASPA, but also here. Mainly, you will see this at the VA, right? The minute you step foot, to use a pun, into the VA, you will see a foot, right? So you will see feet. You will see feet. And not to say that we don't here, we see this all the time, but yeah, that's where you'll really become experts in this. And you need to be, because you will see this all the freaking time, right? So you see a patient with a foot ulcer and somebody who's diabetic. Are they infected or are they not? How do we determine that, right? So you go back to the basics. So do they have redness? Do they have induration? Do they have a wound that's draining? Do they have like swelling and pain? If they don't have at least 2 of those criteria, that is not an infected ulcer. That's just a diabetic foot ulcer, right? So that's the first step, is to just examine the damn ulcer. Yeah. So that's what we do, right? And we've seen dramatic cases where, there's maggots in patients' ulcers, like that's drama, ID drama, but usually you'll see most of the time, like the bread and butter cases will not be as dramatic. I will never forget my first maggot foot from fellowship. Like it's been decades, but I cannot unsee that. So, if you see it once, it'll be seared into your cerebral cortex forever and ever. Hippocampus, I guess. Yeah. So if it's not infected, don't give them antibiotics. Make them follow up with podiatry. And our podiatrists are amazing. They're excellent. They take really good care of these patients. So use them. What are some risk factors for acquiring diabetic foot infections? You can, absolutely. Why not? Get a Q-tip. And you shouldn't use the soft end. You should use the hooky end, right? So, yeah. Probe to bone is an excellent bedside test that is recommended in the guidelines to do if you're confident enough to do it. Mostly it's like, do I go and touch? Yeah, mostly it's that nervousness that prevents people from doing it, but to do it. So Obviously, risk factors are, hyperglycemia, pressure. We all know this, like vascular insufficiency, so smoking, and they're not offloading their foot. Those are all the risk factors. Now, if they are infected, then what do you do next? If they are infected, then you assess the severity of the wound. Assess the ulcer, is the rest of the limb affected, and then do they have any systemic toxicity? And then that's when you move to imaging and calling either podiatry versus vascular surgery, depending on what their circulation is doing, et cetera, et cetera. So this is, again, another algorithmic way of looking at this. So again, if it's uninfected, prioritize wound care. If it is infected, these are the criteria it needs to meet, and then this is how you assess severity. So if it's mild, they do not have any systemic toxicity, right? And usually mild means superficial, so really usually localized to the dermis. You can use PO antibiotics, right? So if they don't have MRSA risk factors, you don't need MRSA coverage. So if they don't have a lot of healthcare exposure, if they're not colonized by MRSA, if the local rates in the community aren't as high, then you don't need to cover MRSA. What's a nice test that has shown high negative predictive value for MRSA DFI? Right. So weirdly enough, it's the MRSA Nares PCR. You would think it's the groin, but it's actually the Nares. There's multiple studies that have shown high negative predictive value. And actually the first one was from a VA population that looked at initially for VAP and then more recently for DFI. The NPV was like 96%. So, but again, this is where we also need to go back in their cultures and look if they've previously had MRSA, then you should include MRSA coverage, appropriate antibiotics. If they don't, then just use amoxiclav, which is great, or just use cephalosporins. That's really all you need to be doing. You don't need to be giving them Flagyl, like none of that stuff for a mild DFI, right? Moderate means they meet 1 or 2, like 0 to 1 SIRS criteria. It's getting deeper. That this can include osteomyelitis in the foot, right? So this is when you might initially need to give them IV antibiotics. And typically these wounds will clearly look infected. They will have more than 2 centimeters of redness surrounding the wound. And so you need to be calling the surgeons already, which usually they will be called in these cases. And then these patients might need MRSA coverage up front, especially obviously if they have risk factors or their PCR is positive. So severe, they have more than 2 SIRS criteria. These are the ones that will go on the table right away. Like podiatry won't wait for anybody. They will just take them. Or if they have a gangrenous extremity, vascular surgery will take them right away for amputation. Or sometimes we see sequentially where the podiatry will take them and then vascular surgery comes in and then fixes their arterial circulation. So we will see all of these. You will see all of these things, right? The whole spectrum. So another point is pseudomonal risk factors. So who needs pseudomonas coverage, right? Florida, we need pseudomonal coverage. It's Florida. We need pseudomonal coverage. Water exposure, recent antibiotics, surgery within the last 3 months. So if somebody has been messing around with their foot for the last 3 months, within the last 3 months, if it's a gangrenous appearing extremity, then include pseudomonal coverage usually. And then water exposure or being Florida man. So if they do, then obviously include pseudomonal coverage. And then another quick point is anaerobes. What the heck are anaerobes doing here? We don't know. They might just be hanging out with the other bug bros, not doing anything. But if it's a fetid, smelling, gangrenous, nasty, wet appearing extremity, use anaerobic coverage. Just do it. And for more severe wounds, absolutely do anaerobic coverage. But long term, they might not need it. And other points for DFI, OM. Obviously, the duration depends on how much of the bone you've debrided. The magic 6-week number is just a magic number that came up in the 1970s. So not everybody needs 6 weeks of freaking antibiotics. Try to use oral as much as you can. We do not send these patients home with 6 weeks of IV. We're just not doing it. We try our best to do oral antibiotics unless there's specific contraindications to do that. And if they've had good surgical debridement and if they have viable margins, then you can stop the antibiotics right away. Most of the times, we're really waiting for histopath, so we are unable to do it. But you should follow up those histopath results yourself and send them out with some oral antibiotics to decrease length of stay. And clearly, oral antibiotics have been shown to decrease length of stay, and they've been shown to have less complications. And there's multiple studies that have shown that they work equally well as IV antibiotics, unless, again, there's contraindications. So if there's a lot of vascular compromise, if there's some concern about GI absorption, if there's so many bugs that you need to cover all of them, and you're going to give them 5, then yeah, maybe not PO, but otherwise you should be using PO. So I just wanted to talk about Oviva. This is the classic trial. It's like now 6 years old. Oral versus IV. So adults with bone and joint infections switching to PO antibiotics within 7 days was non-inferior to switching after 6 weeks, and similar treatment failure rates, and like I said, shorter LOS. So everybody should read this trial. This one looked at 6 versus 12 weeks for PJ. This I just included all the things that you should probably be reading at some point, but 6 weeks for certain cases was shown to be inferior or not non-inferior. And then Truth and Dare is another more recent trial that looked at the duration of therapy and use of the FQ rifampin combo for Staph aureus. Addition of rifampin in that situation didn't show much of a benefit. And then this one, I forgot to include the DOI here, but this was the one looking at the metagenomic sequencing. I can send that to you, but it was from China. Diabetic foot infections, there's new guidelines, like an update either from 2023 or 24, but it has everything you need to know about diabetic feet. It's the International Working Group on the Diabetic Foot plus IDSA guidelines, very thorough and comprehensive. IDSA has a very nice lab diagnosis like update from 2024, which is worth perusing at your leisure. And then this one is a PJI paper, again, that's more recent. So just, I would try to like kind of peruse these things just for funsies when you're on the floors. But I will end with my favorite house MD joke.